So good morning, everyone, and welcome to our 9th session of the Research Data Management Workshop Series. We would like to start acknowledging that we pay respect to the Algonquin people, who are the traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region, from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. So I wanted to remind you that about our next sessions. Exceptionally for next week, we will have 2 sessions in the same week. One on Monday and the other one on Thursday. So we have the benefits of open data for public health with Dr. Doug Manuel on Monday, and we have with Dr. Florian Oded the clinical trials and data sharing. And for the next week, we have Dr. Rochelle Poldrack for talking about Open Neuro on Monday again to our normal schedule. The first 2 sessions are already open for registration on the website, and the third one will be open this week. I hope so. So again, we would like to invite you, if you are interested about research data management and you would like to be part of our project and to become a data champion, please access our website. There is a link there for registration, and you can learn more about the project, the initiatives, and how you can join the team. So today we'll have a talk about Indigenous health data and research at ICES, and we have Graham Mecredy as our speaker. He is part of the Populations and Public Health Research Program at ICES Central. Thank you very much, Graham, for being here with us. This session usually takes around 40 minutes, and we have 20 minutes for questions and answers. So feel free to place the questions in the chat or to open the mic and the camera and ask your questions to Graham directly after his presentation. Thank you so much.
All right, thanks, Anna. Let me just share my screen here. Hopefully you can see that okay. So hi everyone, thanks for having me. As Anna said, my name is Graham Mecredy. I'm a staff scientist within the Indigenous portfolio at ICES. I come from a settler background of Irish immigrants. I grew up in Kingston, Ontario, and I now live in Toronto, Ontario. So I'm going to talk today about Indigenous health data and research and what we do at ICES. There we go. And I know Anna already did a land acknowledgement, but I would like to do one as well, which I guess makes sense since we are in 2 different locations, as often happens with a virtual presentation. But I'm located in Toronto currently, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And is now home to a wide range of different Indigenous peoples. And in fact, Toronto itself comes from a Mohawk word, takaranto, which is allegedly means the place in the water where the trees are standing. And I think that actually originally refers to fishing weirs, which is a way of fishing. But I thought this picture was appropriate. This is a picture I took back at the beginning of October near my place at the Scarborough Bluffs. And you can see the trees sort of standing in the water like that. So I thought that was appropriate. Just at the start, I don't have any conflicts of interest to declare, so nothing too interesting there. But for the agenda, this is what we'll be going over today. So I'll talk a bit about what ICES is, just for those who aren't familiar, to sort of set the stage. Talk about our Indigenous portfolio and what we do. We'll touch on data sovereignty, the different types of Indigenous data that we have at ICES, and talk a little bit about Indigenous data governance as well. So like I said, just for those who may not be familiar already, ICES is a not-for-profit research institute. We're made up of community of research data and clinical experts, and we use data from the Ontario healthcare system to answer important questions. So we are funded sort of, I think it's almost about 50-50 comes from the Ministry of Health, and the rest comes from a wide variety of sources, including grants and things of that nature. So just to get an overall picture of how much data we have, there's about 18 billion records for over 20 million Ontarians, and that's everyone who's ever had an Ontario health card, and that works out to be about 500 billion data points. And I think this slide is actually a few years old, so we're probably closer to the 1 trillion data points mark that it has at the bottom of the slides there. So we work with huge data sets that include basically everyone in Ontario. So it's a huge, huge amount of data that we have to work with. This is just to get a quick idea of the types of data that we have. And the key being a very literal representation there with the keys on the slide, but the key is that everything can be linked together. So each of these data sets that we have an encrypted version of someone's health card number in each data set. So we can find the same people across data sets and across time, which obviously unlocks huge potential in the data and being able to link all that together. So there's different types of things that we have. It's mainly focused on healthcare data from the provincial healthcare system. So there's information about the people and where they live. There's information about the health services that they utilize. So that's really the bread and butter there. So that would be things like people's visits to physicians, to the ED, when people get hospitalized, things like that. There's some information about the providers and the facilities themselves. We have some disease registries, and then there's a small amount of intersectoral data as well, things like environment and transportation. And I think that's an area of growth where there's more different types of data coming in. But for the most part, the main data that we work with is data from the Ontario healthcare system. So switching gears a little bit then, so that's a little bit about what ICES is, and then I'll talk a bit about our Indigenous portfolio that operates within. So I'm a member of the Indigenous portfolio. It's a small but growing team, and basically we're in place to support the Indigenous-driven use of ICES data. So we work a lot with various Indigenous partners, and I'll talk a bit about more about those partnerships as we go along. But really, that's why we exist, to enable the use of the data that exists within these giant databases to be accessed and used by our Indigenous partners. We aim to be a trusted partner for Indigenous organizations, scholars, and communities to use their data to promote well-being, healing, and effective policy. And we aim to listen and learn from Indigenous teachings and principles so that we can apply them in both our relationships and in the broad work that we do. So I know there's a lot on this slide, but this is a framework that we put together in conjunction with one of our partners, the Chiefs of Ontario, who I'll talk a bit more about. But this is sort of how collectively we envisioned Indigenous data governance principles taking shape in the work that we do specifically. So it's broken down into 4 different quadrants there. I can just briefly go through these, maybe starting with data governance in the top right. So we have things like formalized data governance and data sharing agreements that determine how the data gets used. We've thought about things like methodology and approaches, so trying to bring in Indigenous perspectives and models of well-being to the work that we do, understanding different data gaps and data quality issues with the data that we're using, and bringing in additional context that we may not have as researchers that is extremely important to things like interpreting outputs for data. When we talk about evidence to build policies and programs, we thought about things like collaborative research projects, and that's really what the work that we do is. It's a collaborative project. Any work that's done in using the Indigenous data that we have is done in conjunction with partners. So the projects aren't just done by researchers and then sort of presented back to communities, but it's really a collaborative project that where people are involved from start to finish, and the partnership is sort of built that way. And then finally, ethical relationships, thinking about things like Indigenous research ethics, community engagement, which is very important, and I'll talk a bit more about, and then mutual capacity building as well. So there's a lot there, but it's a very complex area. So this is sort of a distillation of the types of things that you should be thinking about when you're doing work in the Indigenous data space. And these are the things that we strive to incorporate into all our projects. So I've already talked a lot about partnerships, but it's one of the most important things that we do in doing work in this area. So we have a diverse range of partners, and really sort of drawing from the TRC calls to action, we've taken a distinctions-based approach. So I know I've already said the word Indigenous many times, and that's sort of the way that we group all of this together. But in reality, when we do the actual work, it's very distinctions-based. So there aren't really projects that are talking about Indigenous data grouped together. Almost all the projects that use the data either are working with First Nations partners, Métis partners, or Inuit partners separately. There are some projects that sort of do group a bit differently, maybe focused on urban Indigenous populations or something like that. But in general, it is a very distinctions-based approach. And this might be obvious based on what I've said already, but really this work is about relationships, and these relationships take time to build, and really they're based on respect between both parties and trust between both parties that the data is going to be used in an appropriate way. And at the end of the day, there's going to be positive benefit that comes out of using this data and not harm. So just on the slide there, those are examples of our data governance agreements with the Chiefs of Ontario over the years. The one on the top there is dated from 2012. So we've been working with some of these partners for a long, long time to do this type of work. And speaking of the Chiefs of Ontario, I'll just go through a couple examples of partners that we have. That again, we've been working with for a long time, but for those of you who may not be familiar, the Chiefs of Ontario is sort of a provincial governing body for the 133 distinct First Nations that are located within Ontario. They do all types of different work. They do a lot of work in the health area, but they have education departments that do work there. They work with justice, they have youth programs, they have all sorts of things that they do. So we work mainly with the health group there, and we've had a close relationship with them for 10 plus years now. Another group that we work a lot with, just to sort of give you an idea of the different types of partnerships, is the Métis Nation of Ontario. So they represent all Métis communities throughout Ontario, sort of a similar setup to the types of things that Chiefs of Ontario does as well, where they govern the data, and then they work with the Métis different regions, and they do all sorts of different programming. So that's a little idea about the Indigenous portfolio and the types of partners that we work with. So I'll move now just to talk a little bit about data sovereignty. And the picture on the slide there is actually from an Indigenous data sovereignty workshop that I went to I guess this was back in 2019 in the before times. But so it was a full day meeting with different Indigenous groups from across the world, actually. There's some from Canada, the US, and from New Zealand. But there was an artist there in the room while the meeting was going on, and they were sort of illustrating the different types of things that we were talking about for the entire day. So I won't go through all this now, but I think the slides are going to be shared later. And I just love this picture. It has all sorts of different concepts that came up throughout that full day of conversation. And there's some really good stuff on there. So when we talk about data sovereignty, we first have to talk about Indigenous data and what that means when we say Indigenous data. So one thing is that it means data about resources and environments. So that's, where people live, information about the land, things like that. It includes data about individuals, which is what we typically think about when we think about health data. We're usually thinking about individuals' data. And then the last point there, it also includes data about nations. And that's usually sort of a divide when we work with people in the health sphere. They're not used to thinking about data in that same way. So say we talk about data from the city of Toronto, where I live. We don't usually have sort of a collective ownership over that sort of data. We could present data about the city of Toronto to any audience and there wouldn't really be any concerns. But when we talk about data about a specific First Nation community, there is sort of a collective ownership around that data that you wouldn't have with just a city in Ontario, like I mentioned. So it really is a different way of thinking about what data is and how we can use it. And some of that stems from the First Nations principles of OCAP. I know there was another First Nations sort of data governance presentation in this series of presentations. So if any of you attended that one, there may be some slight overlap here, but for those who didn't, I'll go through this nonetheless briefly. So the OCAP principles, which some of you again may have heard of before, but they were developed through the First Nations Information Governance Center. It's an acronym that stands for Ownership, Control, Access, and Possession. And basically these principles refer to the rights of First Nations communities to own, protect, and control how their information is used for research or for any purposes. So just briefly why this is important. It concerns, there are concerns with how First Nations data has been collected and analyzed in the past, done without input or review or consent about using that data. So these principles sort of reflect First Nations commitments to use and share information in a way that brings benefit to the community, which at the end of the day is the entire point of using this data, and also minimizing harm while doing so. Again, these cover both individual and community level privacy, which is a different way of thinking. Often epidemiologists and data analysts don't typically think like that. So that's a key distinction. The principles are a tool to highlight the rights of First Nations to govern the information that's collected from their communities and about their communities. And at the end of the day, I think this is a very key point, that they're not there to deter research from happening, but it's there to support meaningful and respectful use of the data. That's often a question we get from researchers is just concerns about deterring research and stopping potentially beneficial projects from happening. But these things are in place to make sure that the research actually is beneficial and it doesn't cause any harm. So a key component of that is engagement. And I think I mentioned this briefly before, but engagement is absolutely fundamental to doing any work in the Indigenous health data area. There aren't any projects that use the data various indigenous data sets that we have at ICES without having this engagement in place. So really, it's absolutely fundamental to doing the work. And then, so this is just sort of again, there's a lot on this slide as well, but a sort of a general overview of the types of things that would be involved when we talk about community engagement. So just briefly, things like community voices. So that would be actually going out to the communities, talking to people, hearing about who they are, where they live, how they live, things like that. The building of relationships, working with leadership and community governance. Again, the OCAP principles are listed on here under the heading of research project development. And community engagement through activities that could take many different forms. Could be going to community events, going to powwows or gatherings, anywhere that you would be invited to partake in and talk about how a potential project could benefit the community. And then finally, a key part at the end is knowledge translation. That's something that's, with any research, easy to not think about until the end, but really sort of needs to be thought about at the beginning, and how the community is going to be involved in the work, and ultimately how that is going to be translated back to the community in a way that is ultimately beneficial. Okay, so next thing I'm going to talk about is the different types of Indigenous data that we do have at ICES, and some more information about each of those. So generally, things are sort of broken down into 4 categories of Indigenous data. The first one being self-identifiers. So there are various data holdings that we have that have variables where someone would have been asked to identify whether they're Indigenous or not. Sometimes these are specific, like it will ask if someone actually is First Nations, Inuit, or Métis, but sometimes they're not. Sometimes they're just sort of broad categories, asking if someone is Indigenous or Aboriginal or all types of different languages used in those types of things. The next category is geographic identifiers. So generally these have to do mostly with First Nations communities, where you can use postal code, residence code, or even census subdivision level information to identify where someone lives, and oftentimes those boundaries line up with the boundaries of a First Nations community. The third column there, registries. This is probably, well, it definitely is the one that we use the most, and is sort of seen by our partners as the gold standard of this type of information. So the first one being the Indian registry system. That's a list of all registered status First Nations people in the province. So that gets used the most when looking at First Nations research. And the second one, the Métis Citizenship Registry. Again, that's a list of all registered Métis citizens in the province as well. So we do a lot of work with the Métis Nation of Ontario, and that's what they use to, that list comes from them, and that's what they use to identify their population. And then the final category of data is Indigenous specific data sets. So there's some survey data that has been conducted within First Nations communities. So we have some information like that through data governance and data sharing agreements with the Chiefs of Ontario. And then there's some data from Indigenous healthcare providers, things like Aboriginal Health Access Centers, if anyone's familiar with that. But there's that type of data as well. So there's a bit of a spectrum of different options. But it's important to think about, obviously there's good things about using each one of those, but they all have limitations as well, which is important to think about for any research project. But I think even more important to think about when we're working within this area. because it can have a big impact ultimately on the results. Knowing who is included in the data, who isn't, and why can have a big impact there. So I'll just briefly go through some of the things on here. So when we think about the general administrative health data, which again is sort of like the visits to physician, hospital, ED, things like that, we don't have federally funded health service data in there generally. So things like NIHB, which is non-insured health benefits, which is something that is used widely with First Nations people. We don't have data from nursing stations, which again are often in First Nations communities. So these are other places where people might receive healthcare services that wouldn't show up in our data. So while they may not have a visit to a physician, they may have gone to a nursing station for something similar. And then it looks like from our vantage point, we can't see that they had any of those services. So there's definitely potential gaps there. And then further, we know that there's vast differences with access to services, whether that be based on geography, like being far from the location that you need to get to receive a service. But beyond that, we know there's cultural barriers as well. The healthcare system can be a very complicated and unfriendly thing to navigate. People deal with institutional racism in trying to access these services. So we know it's not just the distance from a place that says whether someone is going to use that service or not. There are many barriers that can come into play. When we think about the self-identifier data, which I mentioned on the previous slide, we don't use that type of data nearly as much as the registry type of data. Often the accuracy of those variables is unclear. And as I mentioned, they often use generic Indigenous terminology, where most of the research that ends up being done is more distinctions based. So oftentimes those self-identifiers aren't quite as useful for those purposes. In terms of the geographic codes, which again are things like postal codes and residence codes, they're not always as up to date as they could be in the data. They get updated when someone updates their health card, or they have an inpatient service like a hospitalization or an ED visit. So there can be, a couple years gap between when people update those things. And then even when they are updated, using something like a postal code to identify a First Nations community, sometimes the boundaries line up well, so you can tell someone's in this postal code, they for sure live in a First Nations community. But oftentimes the boundaries sort of overlap with a general population community that's right next door or something like that. So it's not as specific when using that type of data. And then finally, the registries, which I mentioned is sort of the gold standard. Those have drawbacks as well. The registration on both of the registries that we have is not mandatory. So we know that there's gaps with those types of things as well. So I think all that is important to think about when you're doing this type of work, and ultimately at the end of the project, when we go to interpret the results, we have to know this type of thing, to know that there's gaps, to know that we may have an underrepresentation of the true health service needs of the population that we might be looking at. So I'll talk next a little bit about Indigenous data governance, and again, that concept has sort of been woven in through everything we've talked about before, but just some more specific examples of what that looks like. So I've mentioned the Chiefs of Ontario many times already, but I think that just speaks to the close partnership that we've built with them over the years. We first entered into a data governance agreement with them back in 2012. And that governance agreement is in place to facilitate research being done while overseeing the use of First Nations data at ICES in a manner that protects the interests of First Nations communities. So in this relationship, when we think about the OCAP principles and sort of how that works out in real time, like in practice. Us at ICES in this relationship, we are a data steward for First Nations data. So something like the IRS, the Indian Registry System data that we have, it sits with us in our ICS like office in our servers. So it's physically, a copy of it is physically located at our office, but we're not the ones who ultimately decide who gets to access it, when it gets access, for what purpose it gets access. Those are things that are sort of outlined in the data governance agreement that oversees the use of that data. So yeah, someone can't just come to us and say, oh, I want to use this data set for this project. We have a whole process in place for doing that. So in relation to that process, the Chiefs of Ontario has a First Nations Data Governance Committee in place to review projects, to review research projects that want to use that data. So when a researcher comes to us and they want to use this IRS data in conjunction with the ICS health administrative data to look at a certain outcome in a certain area of the province or the entire province, those projects get reviewed by this committee to be able to potentially access that data. So again, the committee isn't there to block research projects. The committee is there to ensure that the research projects are done in a good way, that they have their engagement in place, that they've thought about different areas of the OCAP principles and how those will impact the project, that they thought about who they're working with and how that information is going to be ultimately conveyed. And just really at the end of the day, the committee is there to make sure that the data is used appropriately and that there is going to be a positive outcome or a positive benefit that comes from allowing that project to move forward. So in conjunction to that governance agreement with the Chiefs of Ontario, we also have sort of overlapping governance agreements with two other partners, the Kenora Chiefs Advisory and Grand Council Treaty 3, which are both sort of First Nations governing bodies. So each of those three partners, those two and the Chiefs of Ontario, each govern sort of their portion of the First Nations data. So if a researcher wanted to look at a certain health outcome in First Nations people across the entire province, they would have to make an application to each of those three groups in order to sort of gain access to the entire data set for that Ontario-wide First Nations population. So as you can imagine, it's a very complicated process. It's a process that can take a lot of time, a lot of engagement, and yeah, it's there in place to make sure that these projects are using the data appropriately. So it's very thorough. There's different applications to each group that the project would fill out, and they're reviewed at certain times of the year. So yeah, there's a lot in place in order for someone to use this type of data. So all that being said, that's sort of the process for researchers to access the data and how the data is governed in relation to that. But this is a little graphic that's been put together to just sort of show the process when a community comes forward and wants to access their data specifically. So this is the type of request that we get all the time, where we work with a variety of different First Nations communities and governing bodies. So different communities will hear about this type of work, and then they'll approach us and want to see sort of what's possible to look at for their community. So the process is much more streamlined in that sort of context. There's not those big applications to those governing bodies to access the data, because ultimately the data is owned by the community. So when the community wants to access their data, it's a simpler process. basically what happens is all they have to do is get a ban council resolution from their ban council in the community. And that's a requirement of the Chiefs of Ontario, sort of part of that data governance agreement that we have over that data. But really that ban council resolution is just there to show that the community really is on board with having their data access for this purpose. So it like the request doesn't just come from sort of one individual in the community or in the community's health office, but really that there is buy-in at the community level to have their data looked at and analyzed and then provided to them for a specific project. So those requests come to us, and we work, with the community back and forth to see what type of information they need or want, and then what we have that can sort of fill that need, and we sort of build that up from there, and then provide them back a report at the end of the project. So although there is a lot sort of on there, it's much more streamlined than it would be for a researcher to come forward and try and access this type of data. And then just to note also with another one of our partners, the Métis Nation of Ontario, we have a data governance and sharing agreement with them since 2016. We have a committee with them, a governance and partnership committee that meets every quarter or so to talk about these types of things. And then they have an application process as well. If a researcher wants to access the M&O registry data, they have a whole process that someone can go through to access that type of data as well. So just trying to give you sort of a general picture of how these things sort of work in practice. We hear about the data governance principles, like the OCAP principles, which are really at a high level. And then when they get distilled down into what we actually do on a day-to-day basis, it looks more like this, where we have these governance agreements in place that look after the data and make sure it's used appropriately. So that's all I have to formally go through today. So thank you and miigwech to all of you for taking the time to come and learn today. I'm happy to take any questions that anyone has, and we can go from there. So thank you.
Thank you so much, Graham. That's fantastic. Lots of information. I just sort of reach out to the people on the webinar today. If you have any questions, please ask Graham, and maybe I can just sort of start, Graham. I'm trying to sort of frame my question, but I suppose what I hear you saying is that, and always correct me if I'm wrong with my interpretation, that in a sense the Indigenous communities sort of are interested in the data being used positively. Now, from where I sit, if I were to replace the word Indigenous with pharmaceutical company, I would say, well, they want the data where the drug will look good. So is there, it seems to me there's elements potentially of publication bias, or am I completely off track there?
Yeah, I think when we talk about like using the data positively, it's more that it's used in like an appropriate and meaningful way rather than, looking at positive outcomes. A lot of the work that we do with this type of data is very like deficit based by nature, because we're dealing with visits to the health service where people are sick or injured or ill. And a lot of the things are sort of counting up how much illness and injury there are. So a lot of the time it is not positive messages that are coming out of this type of thing, but it's more the spirit of using the data in a way that is beneficial to the communities that we're working with. in terms of like publication, a lot of this work ends up not being published, like might be typical of a lot of health research. Most of them are, I mean, almost all of the work that we do directly with the communities, it only goes back to the communities and they can sort of use it how they see fit. It doesn't really go through the typical research cycle of going to conferences with the data and publishing the data. That obviously does happen in certain projects with certain partnerships. But I would say the bulk of the work that we do on a day-to-day basis with these type of partners is information that just goes back to those partners to use in their community and sort of help with their health planning or their advocating for funding or whatever the types of things that they need to do with the data.
Thank you. Okay, that's good to know. So again, just sort of reaching out, there's a question here from Andy Doherty. If I'm pronouncing it wrong, I apologize. Oh, that's to me. Right, I see. So maybe I shouldn't be saying that out loud. So another, I don't see any other questions. So I will just, I wanted to ask you, if I might, Graham. So I think earlier on and perhaps throughout, I got the impression that, in a sense, engaging with, you know, whether it's a specific community, the Métis, or whether it's to the broader Indigenous groups, that it requires time, it requires, in a sense, developing relationships. And if I'm sort of thinking about outside of ICES, just thinking about clinical trials or observational studies, in a sense, who would pay for that? I mean, when we applied to CIHR, you know, first of all, they cut budgets by usually 30%, but how do you build that relationship?
Yeah, I think that's a good question, and that's an issue that a lot of researchers would have with this type of thing. As like, you know, a lot of research is funded by grants, and which are hard to get and a lot of work to get. But this is the type of thing that needs to be built into those grants in order to successfully do this type of project. Like you say, it takes a lot of time and a lot of effort to build those relationships, and even all the application process and things like that, which also takes a lot of time. Those types of things, like when the project gets to the stage of applying to use the Indigenous data, those applications don't move forward unless there is that community engagement sort of in place already, because that's a lot of the questions that are on those applications about who you're engaged with, how that looks, how they're involved, how they're going to continue to be involved, questions like that. So it's a long and complicated process, and often it can be expensive to do that type of thing. So I think the nature of this work requires that type of thing to be built into the grants that people are applying to
Right.
use those funds towards.
Thank you. So Andy made a mistake in terms of, he meant to send it to the group, not to me. So he's asking, has there been any interest in other provinces with regards to emulating your work? I'm thinking in terms of building relationships among regional representatives and provincial health agencies.
Yeah, so yeah, our work is very much focused on Ontario. Everything I've talked about today is very Ontario specific. I know other provinces are at various stages of this same type of thing. We've been in touch. So just to back up slightly, at ICES, basically all of our data is from Ontario. So that's why our focus is on Ontario by nature of what we're able to do with the data that we have. But there are similar types of things going on in various provinces. We've worked with groups, not really worked, but collaborated and discussed with groups in Alberta and BC who have similar types of broad reaching engagement with both high level Indigenous groups and sort of community level as well. So yeah, in terms of on the project level, there's not a lot of collaboration in that way, just by the nature of the type of data we have. But there are very similar things going on across the country in different provinces. So that's always good to see.
Okay, thank you. Angelica has a question. I understand that there are gaps to the data. What is the impact of this missing data, would you say?
Yeah, that's a great question, and it's something I talked a bit about those gaps existing and how they can certainly impact projects. I think in general, most of the gaps sort of add up to make it that we have an underestimate almost across the board when we're dealing with this type of data, looking at these populations, that we have an underestimate when we use this health service data for those various reasons that I mentioned, sort of difficulty to access the system, not missing certain data sets that might add a more full picture. So there's no like real easy way to account for that other than knowing that it's an underrepresentation of the true service need of these populations. And even still, when we see the results from these projects, depending on the type of outcome you're looking at, sometimes the differences are still staggering, even knowing that these gaps exist. So I think while they're there and that they do have a big impact, there's still a lot that can be done with the data and that we have done with the data, and you can still see huge differences in service use between these populations. So yeah, so they're there, and I think one way that we attempt to account for them is through the engagement process with the partners that we would be working on in any project. So we work with them collaboratively throughout the project, and then sort of at the end we bring the results back and say, you know, how does this look? What's the context through which people are accessing these services? What might we be missing? You know, and sort of try and, while you can't build it in necessarily to the numbers that you're seeing in the results, you can build it into how we interpret that information and try to, you know, build in those stories and the missing context that we have around, you know, why and when people access these services.
Thank you. Angelica has a follow-up. I guess she's asking how can the missing data, how can that be closed?
Yeah, I mean, that's a great question. So from like a epidemiologist point of view, I mentioned there's certain data sources that we just don't have access to currently. So that's one way. We've been working with the federal government to try and bring in some of those federally funded services that are being offered in Ontario that would sort of help to augment the picture that we have of people's health service use in these populations. So from the data perspective, I think that's like the number one thing that we've been working towards in conjunction with our partners. It's not us going to the federal government alone and saying we need this data. Really, that message is coming from our partners, and we're sort of in a supporting role to try and help facilitate making that actually happen, so we can have a more clear picture when we do this type of work.
Thank you. I wanted to just to follow up on that issue with you. So sort of wearing my sort of epidemiological hat, there are many statistical approaches that one could take to missing data. Is the Indigenous community open to that, or they don't allow that, or?
Yeah, I think it really depends on the partner that we're working with. A lot of the time we're working with people who don't have a background in certainly don't have a background in research, but may not have much of a background even in health. Sometimes in communities, people are in roles in the health department and they just sort of have moved around in different roles, and they may not even have a huge background in health. So in general, the type of like statistical techniques and things like that that we've used are fairly simple. There hasn't been, I mean, again, every project is different, but that's often the way it goes in terms of sort of presenting something that's easily enough interpreted, like working with percentages and some rates, like sort of simple types of things that can be more easily interpreted, and then actually being able to use that information at the community level. So I wouldn't say there's like pushback against more advanced techniques or anything. It's more just sort of, that's typically the way that things have sort of organically moved forward, is with more sort of simple counting stats, I guess.
Thanks, Graham. Angelica has another question. Can I ask about OHIP cards? I had heard there was a gap with some Indigenous people not having OHIP cards. Does it impact data collection?
Yeah, quick answer, yes. That's a good question. So like I mentioned, Indigenous people have access to these federally funded health services as well that you don't need an OHIP card to access. Someone would use their First Nation status card or something like that in order to access those services. So I would say we probably don't have an exact picture of how many First Nations people there would be in the province that don't have an OHIP card. We could come up with an estimation, but certainly it is something that would have an impact. Someone without an OHIP card would basically be showing up in none of the databases that we have, which, as I mentioned earlier, are all linked together with an encrypted version of the OHIP card. So that makes it extremely likely that someone like that would end up being excluded from an ICES study or a study using ICES data in that way. There's a few sources where even in the data sets that we have, we can tell whether someone, like there's some where people would still be in there even if they didn't use an OHIP card. So one example we used recently is the narcotics monitoring system database. So that looks at sort of the main thing that it's used for currently is looking at opioid prescriptions. So we can actually go in that database and see there's a variable that says what type of ID they use for the prescription. So as you would imagine, the bulk are OHIP cards, but there are a chunk in there that are First Nation status cards. So we've been working with the groups that govern the registry of First Nations status people and trying to do some work in linking that registry to this narcotics monitoring system database to just do that type of thing, like get some more information on the types of people that are just using status cards and how many people that might be, things like that. So there's sort of little areas where we can try and get at that, but certainly it is an issue that would affect sort of any work that's done at ICES with typically those people would end up being excluded from the work.
Thank you very much. I don't see any additional questions, so it is getting close to time. And really just wanted to thank you, Graham, for a great presentation and answering all the questions. You're in a very important area of research that is I guess, becoming much more important in terms of the federal government's data sharing mandates and how we deal with Indigenous data. So much appreciate your time today, and I'm wishing everybody else a good day. We have that's about it from us. So take care, and thank you, Graham, again, and thank you everybody for coming on, and wishing everyone a great rest of the day. Take care.
All right. Thanks for having me.
Thank
Take
you
care,
again.
everyone.